Hello friends, this is a case of laparoscopic myomectomy. This patient has a large 12 centimeter myoma and this is pan uterus, means it is occupying the entire muscles of the uterus and intending the cavity. So, we are using supraumbilical port, here varus needle is introduced and we are approximately 8 centimeter above the umbilicus, so that we can introduce the telescope safely and we can have the panoramic view while we will perform myomectomy. And cranial traction with the myoma screw can be optimized if you have a supraumbilical port. So, now we will attach the tubing of the insufflator and then we start the flowing the gas at a rate of 1 liter per minute. So, this patient is unmarried girl and she has this myoma. She was not knowing before, but once the abnormal uterine bleeding started, then this ultrasonography was performed and then incidental finding it was discovered that there is myoma. So, now pneumoperitoneum is complete and we are enlarging the incision to 11 mm to put the suprapubic supraumbilical optimum port. So, this is the 11 mm outer diameter of the trocar, inner diameter is 10 mm and we are using it for telescope. So, supraumbilical port is carefully introduced. In those situations, you have to be careful that it should not hit the myoma or it should not hit the bowel. Now, this is the hissing sound and then we will again attach the tubing of insufflator and now rate of flow is increased to maximum flow rate at 10 liter per minute. So, this is over. After that we will introduce the telescope and we will have the initial diagnostic laparoscopy just to visualize that how it looks like, and after that we will decide the another port. This is just cleaning of the cannula and then telescope will be introduced. White balancing and focusing is already done. So, now the telescope is inside. Now, we can see the fibroid and base of the fibroid, you will put the index finger and the thumb over the umbilicus. So, at least 18 centimeter away from the base of the fibroid we should have second port, because after removal of the fibroid you have to do suturing at the base. So, fundus of the fibroid should not be considered as a target, otherwise after removal of the fibroid your instrument will start making class 3 lever. So, this is the second port introduced. Now, patient table is getting 30-degree head down, so that we can move the bowel away and we can see this is a large fibroid, mostly posterior wall, but it is almost occupying the entire uterus. So, it is pressing the rectum and almost filling the entire pelvic cavity, and on the rectum also it is sitting, it is pressing both the ureter as well. This is a round ligament and fallopian tube and ovary is fine. So, this is the initial diagnostic laparoscopy. We cannot use any uterine manipulator. So, now we will start the procedure by injecting vasopressin. So, 5 international unit of vasopressin should be diluted with the 20 ml saline and total approximately 100 ml we will inject the saline, so that there will be hydrodissection as well as transient ischemia will form. If bleeding is started, you should try to bring a grasper and you can just press the prick of the aspiration needle, because the purpose of this aspiration needle vasopressin injection is not only the transient ischemia, its main purpose is hydrodissection. So, you have to maintain the pressure and that is why you should not allow it to bleed. So, suppose the opening is little bigger, then you can hold it by the grasper and then inject the vasopressin. We can see marble white appearance started in the uterus and that is a sign, and the transient ischemia is forming. You should also look at the parameter like the pulse and the other thing of the patient, because it can create sometime the difficulties in the pulse rate, and anesthetist should also be must informed while you are injecting vasopressin. Now, here we are giving the incision on the posterior wall of the uterus, and that is the oblique incision. However, if it is a posterior cervical, then we should give vertical incision, but it is in the fundus and the body part of the posterior wall. So, oblique incision will do. We are using here harmonic scalpel because this is the best instrument to cut the seromuscular layer, because it will coagulate as well as cut, and once it vibrates it breaks hydrogen bond, and then it creates its own plane of dissection. So, monopolar is not a very good instrument to cut seromuscular layer in the cases of myomectomy. So, this is, you have to be also be careful that intramural part of the tube should not be damaged, because patient will have infertility issue. Most of these patient has the main question that uterus function should not be disturbed. So, that is why incision should be given in such a way that your incision should not reach till the tube. So, we are going more posterior because it is mainly the posterior wall. This patient has other two small fibroid also on the anterior wall. So, this latter we will remove, but first this bigger one has to be removed. So, now we can see this is a good plane, and slowly with the combination of the blunt as well as sharp energical dissection, you can start mobilizing it all around. Incision should be good enough so that it can bulge the fibroid out, and then you can easily remove it. You can use Myoma rod also, and sometime we use Myoma screw for stabilizing. Myoma rod is for blunt enucleation, and Myoma screw is for holding the myoma. So, now seromuscular incision is over. After that, we will start using the Myoma screw. Here we can see this is the tube. So, we will remain away from the tube. So, if the bleeding happen on the muscle margin, you can use minimum vibration of the harmonic, and sometime we keep the minimum at 1, then the vibration will be 15,500 vibration per second. So, by default once you will switch on the harmonic, the minimum is set to 3, but sometime we bring it to 1 so that it can create more coagulation. Now, slowly by pushing and pulling technique, you can keep on bluntly separating, and if you have a good plane, then this separation will be easy. And take care that when muscle is found, then must use energy, otherwise you will start bleeding. This type of fibroid is very vascular, and the effect of vasopressin is only on the fundus part, because this fibroid as panmural means it is occupying the entire muscle and pressing the cavity. Cavity become very small in those cases. You have to be also careful that try your best that cavity should not open. If cavity is open, you have to separately suture it, but if you will keep an eye on the correct plane of the capsule of the fibroid, then most of the time you can save the capsule and you can perform myomectomy without opening the cavity. So, once the myoma screw has reached to the anterior part, then you can relocate the myoma screw to optimize the again traction. So, again base of the myoma screw should be applied, and again by pushing and pulling technique you can separate it. All around symmetrical dissection is better than going to one side. Sometime if it is required, you may little bit more enlarge the incision rather than breaking the fibroid, because in open surgery you have a finger, beautiful finger through which you can do articulation, and with the smaller incision also you can try to remove, but in laparoscopy size of the incision is relatively bigger than the open surgery in most of the time. However, if you have a good suturing skill, you can suture it nicely in 2 or 3 layer and there will be no issue in the strength of the uterus. We can see a lot of cranial traction is required with the myoma screw. That is why supraumbilical port is essential. If you will put the port in umbilicus, you will struggle a lot and your myoma will touch the tip of the telescope and myoma screw may break the telescope. You can see that repeatedly telescope is coming inside the cannula when the camera person want to show the panoramic view. Then in spite of being the supraumbilical port, there is a difficulty in holding the telescope. Now we can see we are reaching nearer to the cavity. So, basal layer should be carefully separated so that cavity should not open. If you will abruptly try to perform the surgery, then you may enucleate the entire endometrial lining and then it will be a big problem and the menses of the patient may stop. So, these type of myoma generally we say panmural, that means anterior and posterior wall both is affected, and as you can see almost the entire uterus is bisected horizontally because it is completely compressing the cavity. Once you reach to the base, then little more harmonic should be used rather than blunt dissection, because of two reasons. One reason that it can bleed, another reason is that if you will do abrupt blunt dissection, then it can completely strip out the endometrial lining. So, it is better that you keep on using a good plane. We can see this is the cavity, but it is still not open. So, almost 75% of the separation is over, but just to prevent the opening of the cavity, we are little slow and trying to push the lining down. This fluctuation what you are seeing is the outer layer of the endometrial lining, basal layer, and that is bulging out. This one, this is bulging out, but it is not open. So, it is now 80% is out, and this bulge what you are seeing is the bulge of the cavity. Entire uterus is completely everted, anterior wall has gone down and posterior also down, and cavity is bulging out. So, now only last part is remaining. And this is separated. So, it came in total, we can see this is the cavity. So, you will take two atraumatic grasper and you can pull the seromuscular layer from anterior to posterior to push in this bulge part of the like this. Now, it has gone in, and endometrial lining was kept in the normal anatomical position. And now, we will start suturing. So, here we will do little suction irrigation, and now here we are using barb suture already this is V-lock, that is a barb suture. Already we have made the this loop, bigger loop, introducing the needle in the smaller loop. So, it is already locked, and then we will start suturing 3 layer. This is the first layer near the endometrial lining, so that it gives a strength, and second layer because it is deep muscular. So, you can suture in 3 layer also, 2 layer also some people they do, but if it is intending the cavity, then better to take 3 layer. This is deep muscle to muscle. Barb suture has a advantage that every 1 millimeter it has a spike like projection. So, it grab the muscles of the uterus and it remaining little tighter compared to this is a 3-port surgery. Generally most of the myomectomy we only perform by 3-port, because myoma screw and the dissecting instrument both should be in the hand of the surgeon. Ambidextrity is required, and if the assistant is holding the myoma screw and he is pulling for you, generally you will not get ambidextrity. That is very important. Left hand should hold the suture to give traction, and right hand at least 1 centimeter thickness of the muscle bite you should take at one time. Do not take on the margins of the muscle, otherwise it will cut through, and serosa should never be included in the inner layer, otherwise the margin will get everted. So, the suturing of the muscle layer was started from the right side, and we have reached up to the left. Just couple of more bites, and then with the same suture we will return back for the second layer of the muscle. patient should not conceive up to 6 months post-operatively, and you should try to do the ultrasound or some other investigation before advising, and cesarean section is ideally recommended for this type of myoma. So, now returning back with the second layer of the muscle. Take care that barb suture has a tendency to grab the momentum, or to spikes can catch the serosa. So, it should not be trapped into that. Time to time, by the open jaw of the Maryland, you should try to keep the suture tight. And now this returning back second layer will finish in couple of suture. After that, we will exit to the serosa and then again returning back to the left. So, the length of the suture, if you are using double layer, should be 4 times to the incision length, and if you are doing 3 layer, then 6 times to the incision length. But sometimes that much big suture is difficult to handle in the laparoscopy. So, sometime when you return back to the serosa, I think these are the other fibroid which we will later remove. So, now we will exit to the healthy serosa and then again started returning back. And this time serosa to serosa bite will be taken, muscle will not be included into that. You may use baseball suturing or continuous suturing. Muscle baseball is never used. Baseball is only used for serosa, and here we can use, and then slowly it is separating, returning back. Whenever you pull the suture, be careful that always pull the needle cranially, because sometime accidentally if you will go laterally, you can prick the iliac vessel. So, handling of the needle should be very careful, especially in the large fibroid. So, little suction irrigation is done. Now, in the barb suture, the near the needle, at least 6 centimeter of the suture does not have a barb, that part is plain. So, it is better not to reach up to the end, and you can cut the suture and you can start another one from other side, and once you reach to the first one, then you can suture together. So, we are cutting here the suture and the remaining barb will be removed. Remaining suture is removed. Now, we have the another suture, and that loop again is started, and we will start closing the serosa from the left side, and once you reach to the middle, we will tie the knot to combine both of them. So, there is a loop again, and here only serosa bite is taken, and you will pull the needle through the larger loop and it will get locked. By default, the barb suture has a small loop, but we convert into large by passing the needle once through the smaller loop outside the abdomen. We can see that we are not completely at the corner of the left side. So, you can come couple of step back and then you can, we have enough suture because this suture is only for serosa. So, remaining suture we have a lot of suture. So, we just couple of step returning back to completely approximate the serosa. And then again we will progress to the right side. Suturing skill is very important in the laparoscopic myomectomy, and that need a lot of practice. Generally in our course we teach 12 type of knot, because only one type of knotting will not work. Sometime extracorporeal, sometime intracorporeal, sometime dandy jamming knot, continuous suturing, Aberdeen termination, a square knot, Melger's knot, all is required in different situations. In serosa also, at least 1 centimeter away from the margin of the serosa, your needle should exit, otherwise there is a tendency of cut through. Because in open surgery you have assistant who is keeping it pressed, and that gives you a lot of ease of suturing, but in laparoscopy you have to do the suturing as well as tensioning of the suture yourself. Generally we do not ask, although we do not have a foreport, but even if you put foreport, we do not ask the assistant to pull the suture, because that way they cut the suture and strength of the suture will be compromised, because excessive traction the suture will break, and especially barb suture breaks more easier than the simple vicryl. Because of laser cut they are little weaker. So, it is reached to the previous part, and now we will terminate it by the surgeon's knot. So, or a square knot. Even if you do not terminate, nothing happens. That is why people are using barb suture, that they do not have to worry about the termination, but ideally termination is a good idea and we should suture it. Here you take care that it is little difficult for the barb suture to slide over your Maryland. So, it should be carefully tightened, because it has a lot of memory compared to vicryl. However, termination is not required. So, every time we have taken double wrap. So, that is why third one we will not take. So, it is over. After that you can trim the suture, you can trim it by the scissors or by the harmonic, whatever you want. This difficulty is due to memory of the barb suture, and now it is cut. This is the third knot also. We can see we are right now we are cutting little bigger, but later we will trim it because a spike of the barb should be ideally not touching the bowel. Now, these are the some small subserous, a small daughter myoma which we can remove it. Just you can remove by the harmonic, you do not need to suture, because it is grade 0 completely outside and it is not taking any part of the muscle. So, left hand has a traumatic grasper giving the anterior traction, and with the right hand slowly you can separate it. You should keep those fibroid carefully, because later you may miss it. So, we will keep over the anterior cul-de-sac. Now, another one is here, that also will be removed. These are also completely subserous. However, it does not affect the infertility of the patient, but after many years it will become bigger than the existing size. So, just one incision was given on the serosa, and then holding will be better, because sometime it slips, because serosa is a smooth. So, if you will give one cut, then holding will be easy with the tooth grasper, that is the traumatic grasper. Traumatic grasper is a replica of the Ellis forceps which we use in the open surgery, but tube or other things should not be touched with the traumatic grasper, because as the name suggests, it can create a lot of trauma to the delicate organs of the body. So, it is only used to touch the fibrotic tissue, fibroid, or sometime in endometrioma also it is required. So, this is done. Now, we will start morcellation. I will not show you the entire morcellation process, because as you know, morcellation takes time, and this patient is only 23-year-old patient and unfortunately developed this fibroid. So, I will not show you the entire process of the morcellation, because unnecessarily it will take time, but take care that all the myoma, we have 3 right now, all should be removed, and at the end port closure is also essential. Sometime morcellation take more time than the surgery itself, and patience is required, and carefully you have to do morcellation, so that any sigmoid or the omentum or a small bowel should not be trapped on the blade. Here we are using a starch morcellation. If the patient age is more, we use contained morcellation in more safe endo bag, but in the young patient it is not necessary to use, because it is a completely single use endo bag where 2 port isolators are there and it is expensive. So, now here at the last of the surgery we are using port closure. Port closure is must, otherwise hernia will develop in those situations, and because this port is 15 mm for morcellator, so port closure is essential. So, now the suture is introduced inside, this is, and then pulling it out and then tying the knot. So, thank you very much for watching this video. Have a nice day.